Start now. Good morning, everyone, and welcome to this Latin American Working Group speaking series on financing surgical system strengthening as a key enabler for implementation. We have made a few changes recently, and we apologize for any impact this may have had on your availability to join us today. However, this session will be recorded and made available for everyone. It is a real pleasure to have you with us today for a conversation that is both timely and essential. So over the past several years, as you all know, global surgery has made important progress in positioning surgical obstetric anesthesia and emergency care here, not only over the globe, but especially in Latin America. But as many of us know, also recognition alone is not enough. Implementation requires political commitment, technical planning, institutional capacity, and very importantly, sustainable financing. And this is why deepening in the conversation on financing is not only a priorities can create mandates and set different shared visions, but policy alone is insufficient if it's not accompanied by a realistic and sustainable financing plan. For Latin American, this discussion is particularly important because many countries are already having strong technical, are building strong technical capacity, are moving forward different commitments and growing political recognition of the importance of emergency critical and operative care. And the challenge now is how to make those commitments implementable. And that requires thinking beyond traditional funding streams and exploring more innovative financing mechanisms. In this sense, financing is not simply about finding money. It is about creating the conditions for transformation. It is about ensuring that surgical care is not treated as an isolated service, but as an essential platform for equity, resilience, universal health coverage, and health system performance. That is why we're especially grateful to have such an exceptional group of speakers with us today. We are honored to welcome Dr. Elise Hansen and Dr. Nardos Olfeta for the program of Global Surgery and Social Change at Harvard Medical School. The PGSSC has been one of the leading academic and advocacy platform for global surgery, with a strong focus on surgical system strengthening. For today's session, their contribution is especially important because the PGSSC has developed significant work around surgical financing, including a financing framework that helps governments and organizations think through different sources of financing. We are also pleased to welcome Dr. Taylor Bourne and Joan Manrique from the Women's Health and Economic Empowerment Network, known as WEN. WEN's work is highly relevant to this conversation because it connects health, economic empowerment, gender equity, and innovative financing. We're very happy to have you here, Joan. She's the president of the Center of Global Health and Development and co-chair of WEN. And both organizations have been leading voices in advancing the idea that health investments, particularly those related to women's health and empowerment must have moved from theory to action and from action to scalable solutions. So today's conversation is designed to bring these two perspectives together. And our hope is that this session helps us to think out of the diagnosis level, but to start thinking practically about how can we um, improve this innovative financing in the region, how countries can build stronger investment cases for surgery, and how surgical financing can be linked to universal health coverage and health system strengthening, and how regional actors can support implementation. With that, we will begin today's agenda with we will hear first from the PGSSC on financing surgical system strengthening, evidence, mechanisms, and opportunities for Latin America. And then we will hear from Wen on applied experience and potential replication on the region. And finally, we will open the floor for questions, reflections, and discussions on possible next steps. So thank you to our speakers and to everyone joining us today. We are very grateful for your time and your expertise and commitment advancing equitable access to surgical care. Thank you very much. And Elise, the floor is yours.
Thank you so much, Majo, for inviting us here. We're very happy to be here today. I am just sending you a share request so that I can share my screen. All right. Is everyone, let's see here. Just a moment. Thank you for your patience. I'm trying to get my screen share here. Okay. Is everyone able to see this title slide now? Okay, great. So as Majo said, Nardos and I will be speaking to you about the surgical financing framework that the PGSSC has created, and we will be sharing some examples from the Latin America and Caribbean region. So we'll start with an overview of the health financing framework and the different components of that framework. We will touch on the current evolutions in the global health financing landscape, and then we'll go into some examples from the Latin America and Caribbean region. We'll then switch over to hearing from our speakers from WEN, and then we will follow up again with some summary and findings from our workshop that we held last year in Colombia. So I'll hand it over to you now, Nardos.
Thank you, Elise. Good morning and good afternoon, everyone. Thank you so much again, Majo, for this invitation to share some of our work with you. So let me start with our why we started this work. And post-Lancet Commission in 2015, different countries committed to developing national surgical plans, which are comprehensive strategies that aim to strengthen surgical systems and increase access to surgical care globally. But despite around 33 countries developing these plans and renewing them, implementing remains very variable. And the main limiting factor has been lack of financing. So we wanted to quantify how much money does actually go into surgical care. This was necessary to lay the groundwork for any advocacy that we were going to be doing, and of course, understanding how financing affects implementation. So what gets funded gets done. So as we look at the different actors in the next few slides, and it's important to note that no single financing source can support the full surgical system. It's important to map out who the stakeholders are and what each of their contribution looks like. So this is what led to our work, a comprehensive approach to financing surgical care. So I have given you the QR code here, and the link is also there. You can visit this at your leisure. We have 1 hour videos for each 8 papers, and then, of course, a 25-minute summary that we actually had the opportunity to share at the WHA last year at the G4 Alliance meeting. Next slide, please. So this is the PGSSC surgical financing framework. We classified our funding sources or stakeholders into external assistance, public, domestic, private sector as the main pillars. And in external assistance, we have bilateral donors, which is government-to-government donations, multilateral organizations, including the UN system, development banks, Gavi, and then, of course, external philanthropy. This is noted specifically as external philanthropy because there's a growing role for domestic philanthropy in LMICs in growing economies, as we'll see later on. And then the second pillar is public domestic, where we looked at government budget allocations and public health insurance systems. And the third one is one of the most important ones, the private sector, which is playing an increasing role in supporting surgical system strengthening. And it's one of the most flexible sectors where it can be a direct service provider. It can support public systems through public-private partnerships. There's also a nonprofit private model, and then, of course, different types of private investments. And then there are cost reduction strategies and innovative financing mechanisms, which are kind of cross-cutting across all these 3 pillars. So cost reduction strategies aim to maximize efficiency of existing resources, either through local manufacturing that reduces the cost of procurement, or technology-supported delivery, which usually works with the private sector, or creating centers of excellence. And then innovative financing mechanisms such as blended finance, which puts together different sources of financing together, or debt swaps, where governments forego existing debt from LMICs, and the LMICs in turn invest that debt into their healthcare systems. So these mechanisms are an interplay of what is already existing that support, sustainable financing to surgical care. So next slide, please. We're going to look at the external assistance briefly. So development assistance is a critical avenue of financing healthcare systems in LMICs. It's believed that around 2/3 of sub-Saharan African countries rely on development assistance to support up to 1/3 of their annual health expenditure. A significant amount of money is moved as external assistance, but when it comes to surgical care, this is the picture that we got from publicly available database that we analyzed. So you can see the proportion of money from each stakeholder that actually went into surgical care. Bilateral development assistance, out of billions of dollars, only 1.84% went to surgical care. From multilaterals, it's even worse because the multilateral system is dominated by these vertical funds, such as Global Fund and Gavi, which are more focused on communicable diseases. And then external philanthropy, where only 0.09% of it went to surgical care. So when we look at the total sum of money that went into surgical systems in the past 10 years that we analyzed, only 3.7 billion of 522 billion went into surgical care. This shows that there's significant, systematic underrepresentation of surgical systems in global health financing landscape. So key actors such as, go back to the previous slide. There are key actors, bilateral actors such as Canada, the US, Australia, Italy, that led bilateral assistance to surgical care. Bilateral assistance has been criticized for not aligning with recipient priorities. But some bilateral donors actually show high levels of alignment, where Italy, for example, dispersed around 34% of their development aid to surgical systems. So it's key identifying which stakeholders align with these priorities. We also looked at who the implementing partners were. NGOs were the main implementing partners for bilateral systems, which means that there's a high risk of fragmentation and parallel system creation, which weakens existing healthcare systems and LMICs. This is one of the weaknesses of bilateral aid. For multilateral organizations, the banks were the leading donors to surgical care. And like I said, despite the landscape being dominated by the vertical funds, the banks actually are strong partners and increasing their disbursements to health despite the decreasing overall development assistance that we noticed since 2025. And then, of course, philanthropy, where a few organizations stood out in supporting surgical care, and their disbursements also went to NGOs, both international and local NGOs, and they also invested heavily in academia. Next slide, please. Another interesting finding from the analysis that we did was, where does the money go? What were the priority investment areas for the different stakeholders? So both bilateral and multilateral partners actually supported health system strengthening, meaning more of infrastructure development, strengthening blood supply systems, etc. Philanthropy, on the other hand, digressed away from, overall system strengthening into supporting specific surgical specialties. So philanthropy comes in as the ideal partner if we have a focused development agenda. But one thing we noted was that across all of these donor groups, anesthesia and critical care was consistently least funded, which is a critical gap given its centrality to surgical systems. So these were the highlights that we got from our analysis of external financing. And of course, there are also findings from the private sector and domestic allocations, which we don't really have time to dive into. But I want to briefly touch on the evolving global health financing landscape with the changes that we saw since 2025. Next slide, please. So with the changes in the US global health strategy and following which multiple other bilateral donors also reduced their disbursements, we were kind of exploring what this means for low and middle income countries, who is going to take up that space, what's the role of the private sector, as well as how are philanthropies kind of going to be compensating for these gaps. Most multilateral organizations are undergoing significant reform as a result of this changing landscape. And then there's a significant rise in domestic philanthropy. So philanthropy alone, in terms of scale, cannot fill the gap. But this is where innovative financing mechanisms come in to combine the strengths of philanthropy, the private sector, as well as public financing to potentially provide LMICs with sustainable financing in their surgical systems. So I'll hand over to Elise and Taylor at this point.
Thank you so much, Nardos. Now that we've covered a conceptual framework, I want to shift us into a few practical examples specifically from the Latin American Caribbean region. So the aim here is just to show a few examples of what is already happening in the region. It's by no means a complete list. When discussing surgical financing in this region, we must acknowledge, as I'm sure everyone listening to this knows, that the region is very large and diverse. So health financing structures and per capita spending vary widely. And so one financing tool or mechanism may look different across settings. Growth in health spending is occurring alongside a shifting burden in non-communicable diseases, and this is driving surgical demands, an increase in surgical demands in the region, making this conversation even more timely. Fragmentation and high out-of-pocket spending remains common across the region, contributing to access gaps and financial hardships. And so with this in mind, I'll move into a few of our examples. So for domestic spending in the region, domestic financing can target different financing objects. So for example, growing new capacity, reactivation of idle assets, or buying more services within an existing system are some examples that we came across. So in Colombia, the Zapiquera Regional Hospital is an illustration of using domestic public funds pooled from different levels of government to complete a major tertiary level facility with surgical services. In Mexico, operating room reactivation under the IMSS Bienestar system renovated non-functioning operating rooms to increase the number of functional operating rooms across multiple states and had a big increase in productivity. In Brazil, a broad approach can be seen with their national waitlist reduction program, which seeks to expand access to elective surgeries, complementary diagnostic tests, specialized medical consultations throughout Brazil, and the funding is national but distributed to states, and the program execution is carried out by the states. Moving on to examples from public-private partnerships, these are, again, quite varied, and countries use them for different purposes. In Mexico, we see an example of infrastructure and maintenance partnerships where the private partner, in this case, a private Mexican company, can be responsible for the design, construction, and maintenance of public hospitals. In Jamaica, the Jamaican Project Code Care is an example of purchasing additional elective surgery capacity via contracts between private hospitals and public hospitals to reduce the surgical backlog. So in this, patients awaiting elective surgery for a specified time can get particular procedures done in private hospitals paid for by the public system. In Guatemala, we have an example of a public-private partnership where the private partner is an NGO rather than a for-profit entity, with the partnership between the Unidad Nacional de Oncología Pediátrica and Fundación Ayúdame a Vivir. Over time, this partnership has shifted increasingly towards domestic ownership, enabling sustainable delivery of specialized pediatric surgical oncology. For multilateral development banks, we again see that support can be structured around different financing objects. In Jamaica, the Spanish Town Hospital Redevelopment Project, in partnership with the Inter-American Development Bank, as well as a grant from the European Union, represents a major facility upgrade, including expanding physical infrastructure, diagnostics, and critical care. In Brazil, the Smart Hospital project, supported by the New Development Bank, along with funding from the government of Brazil and the government of Sao Paulo, illustrates financing in new capital investment. So this facility aims to be a technology-enabled facility focused on emergency and high complexity care. An example of a partnership for broader network strengthening can be seen in Guatemala in the Programa de Fortalecimiento de la Red Institucional de Servicios de Salud. And this is an ongoing initiative supported by the Inter-American Development Bank to reduce maternal and child mortality by modernizing the national healthcare network and improving quality, timeliness, and efficiency of healthcare services. One final category I would like to highlight that is already strong in the region and shows a lot of promise is regional cooperation. So some examples here are the PAHO Strategic Fund, which is an important pooled procurement mechanism, helping member states and territories leverage economies of scale to secure essential medicines and supplies more reliably and at lower cost. Similarly, the Organization of Eastern Caribbean States Pharmaceutical Procurement Service supports the procurement process for member states. And in Central America, the Comisca Negociación Conjunta model uses collective negotiation to obtain better terms and prices, while countries may execute purchasing through national procedures. Regional cooperation can also include regulatory safety and quality infrastructure. For example, the Caribbean regulatory system and related pharmacovigilance and quality systems, which are not surgery specific, but underpin safe perioperative systems. And we think there's likely room to expand regional cooperation for surgical devices, consumables, and other essentials. This was also a topic of great interest, regional collaboration in the workshop that we held, and we will tell you more about the workshop after we hear from our colleagues from the Women's Health and Empowerment Initiative. So I will pause here and turn it over to them.
Great. Thanks so much, Elise and Nardos and Maho, for having us join today. I'm just going to take a moment to share my screen. And is everyone able to see this?
Looks good. Yes.
Great. Well, it is such a pleasure to be here today, and thank you to the PGSSC team for providing such a comprehensive background on financing globally and in Latin America for surgical care and for the different aspects that were brought up. At WEN, we are a global network of philanthropists, investors working with local governments, with the private sector, looking specifically at that innovative financing angle. So a little bit of background on us. So we have, been a trusted partner for a long time. We always say we've been doing blended innovative financing structures really since before it was a hot topic of conversation. Now you go to the WHA, you see a lot of these, a lot of sessions about it, but we've been doing it for about 15 years. So we've mobilized over $1 billion in capital, working across 6 continents, and having reached 50 million people. So that's really the amazing impact of blended finance, is that you're able to have this scaled effect, which brings me into just a quick overview of what exactly is blended finance. It's a word that we hear very often right now, but is not always well defined. So essentially, blended finance is the strategic use of public or philanthropic capital to de-risk and mobilize private investments into markets that it wouldn't otherwise enter. So when we're looking at areas like surgical care or like women's health, we would go to some of our private capital providers and they would just kind of completely write it off and say, we're not investing in health, there's no returns in health. But when we were able to bring in some of our catalytic or philanthropic capital, so money that's just going into a vehicle and it's going to kind of sit there and absorb any potential losses that private capital would have in a specific deal, that's when we would get that mobilization and that scaled effect. And something really great in Latin America specifically is that Latin America has the highest level of capital mobilization in the world of any region. So when you're looking in Africa, Southeast Asia, you still have the scaled effect. But for every $1 of philanthropic capital that's put into either a deal or a facility or a fund in Latin America, we're seeing returns of 4.7% or more, which is the highest in the world. This is just a high-level overview of kind of the different tranches that are used in a blended finance structure. So we have that grant technical assistance financing seeking no financial returns. And that really provides a strong base for any deal structure when we're looking at essential aspects of health systems that a lot of the time they're never going to make money, whether it's a healthcare worker or, building up that initial investment in an electronic medical record system. These are really essential backbones, but they're not going to, provide a return. So that will sit at the base layer. Junior first loss capital can act as a grant, but it can also receive financial returns if an investment is successful. So if an overall deal structure is seeing high returns, then the junior first loss capital will get repaid. And then we have the subordinate and commercial capital. Commercial capital is private sector seeking market rate returns, and whether that's in debt financing or in equity deals, they would be the first to be repaid in a deal structure. So blended finance can be really key for unlocking surgical outcomes. As mentioned, we're seeing every $1 of catalytic capital mobilizing $4.70. 17% of all global blended finance transactions are targeting Latin America and the Caribbean, and I think that that's a trend that we'll continue to see grow. As Elise outlined, there's amazing regional coordination in Latin America. There's amazing development banks that are thinking really innovatively about how they're deploying their money. And there's great entry points for blended finance. So if we're looking at different layers of capital, if you're looking at health infrastructure finance, which is where we see a lot of private investment, that's where you can bring in some concessional loans, commercial capital. We're looking at local manufacturing, and that's an area that we see as really strong and as an area for a lot of private sector interest currently. And you can bring in some initial de-risking concessional capital. You can bring in guarantees. You can bring in that true commercial capital. Surgical workforce, as I mentioned, technical assistance is really critical here. And because human people are the backbone of making sure that healthcare can be delivered at the last mile. And this kind of my high level background, this will take me into the next section of discussions, which is some of the models that we've done through when in blended finance transactions. So I'll start with one of the vehicles that we structured and launched about a year ago in the Indo-Pacific. So we were approached by the government of Indonesia, who had just received a $4 billion loan from the World Bank for broad health system strengthening. And we're looking through it and we're seeing, okay, there's a lot of gaps in this overall system where some of the financing isn't going. One of them is training workforce. Also looking at supply chain, looking at the local manufacturing, the energy and infrastructure systems. So we started working with them to create a sustainable finance TA facility. So through this facility, we would house grant capital that could be deployed in one of two ways. So for one, we can provide direct technical assistance grants to either companies, to training organizations, to governments, regional and national, to be able to strengthen and fill some of those gaps. So whether it's making sure that there's a great training of trainer framework within referral networks for training healthcare workers, or it was disposing of biomedical reagents from the new diagnostic systems that were being integrated. And the second way that we were able to use our capital is looking at what investors are participating in the ecosystem. And something that we learned is there's a lot. There's a lot of people who are investing in health, a lot of investment firms that are investing in data, AI, technology, and a lot that are investing in energy and infrastructure. So as we were looking at this, we saw that a lot of the investments weren't necessarily impact driven. And so what we are able to do is provide with that grant financing, some of that de-risking capital to private equity firms in order for them to take some higher risk investments that will have a broader impact. And the final example that I will go through today is a financing mechanism that we structured with the government of Canada a few years ago. And this was actually based in Latin America, focused on women entrepreneurs and entrepreneurship. And this was able to be rapidly scaled because of what kind of we always discuss as matching commitments. So when the government of Canada was able to provide that $10 million in first loss capital, it actually unlocked an additional 20 million, one from one of our close private equity firms, Serona Asset Management, and then from the USDFC. So through that, we were able to get 30 million in junior capital, which in turn has the scaled catalytic effect. So I think as we're looking at blended finance and different structures that can be implemented in Latin America and for surgical care, we need to look at who are the capital providers that can provide that de-risking capital. So is it some of the DFIs in the region? Philanthropy provides a really great entry point for that, because that is how we get that scaled effect and how we can reach millions. So yeah, that is, and I will turn it back to Elise to discuss the great session that we had in Bogota.
Thank you, Taylor. That was great overview of blended finance. Let me share my screen again here. Oh, I am sharing it, but I will put it into presentation mode. Okay, can everyone see my screen? Yes, okay, great. So we welcome any questions or discussions on this, but we've been repeatedly referring it to it. So I wanted to give just an overview of a workshop that we held last March in Colombia. Importantly, this was put on by many people. It was a large collaborative effort to bring this to life. So we have to thank our colleagues from Operation Smile, Universidad de La Sabana, where it was held, Corporación Latinoamericana para la Salud, and then also the WEN was key in organizing this as well. So this was a 2-day workshop and was to our knowledge, inaugural regional financing workshop. And we think it started a great conversation, and we hope that it will be the first of many more in this region and globally. So the goals of this workshop were to explore regional collaboration, private sector, and external partnership opportunities, to share expertise, best practices, and challenges, and brainstorm strategies together, generate ideas and commitments to take home, and to start a conversation to continue moving forward. Importantly, as I will show you on the next slide, the attendees of this workshop were from various countries within the Latin America and Caribbean region. And so all of this sharing that I've been talking about is it was sharing between countries and trying to increase collaboration and knowledge sharing in the region. So we had government representatives from 12 countries in the region. I've shown here on the map which countries had delegates coming to the workshop. We also had representatives from the private sector, as well as from industry, academia, development banks, and insurance companies, both public and private, really to try to get all of the key actors together in the same room discussing. The workshop was held over 2 days and included opportunities for countries to share their own experiences through country-led panels. We heard from some ministers of health, development banks. We heard from blended finance experts from WEN. We also had talks on legal and regulatory issues for public-private partnerships and how to kind of facilitate better public-private partnerships in the region. And we heard from the private sector, implementation partners, and finally we finished the workshop with what we called a co-design session, where country delegates were paired with delegates from other countries, and they sat at tables together, brainstorming what they wanted to bring back to their country and what ideas they had based on what they had heard in the workshop. So this was just really the start of ongoing conversations that we hope will continue. So there are several ideas that came out of this. One was the creation of a financing network for Latin America and Caribbean. So this is still in very early conversation stages, but the idea is to have a government-anchored regional platform that could help countries translate surgical system priorities into structured financeable opportunities. And this would not provide the actual funds, but would provide the convening structure, technical support, evidence base, and financing facilitation needed to move these conversations towards country-led implementation. And the ideal would be to connect ministers of health with development banks, development finance institutions, private sector actors, blended finance experts, so that the opportunities such as what we just heard from Wen could actually take place in the region, and people know what the opportunities are and can connect with them. We also plan to hold a second conference next year in the region, and we hope to have even greater attendance next year. And so that's all I have for now. We welcome any questions, further discussions about this, and thank you so much again for having us here.
Thank you all so much for this incredible information and for the valuable reflections you have shared with us today. I would like to open the floor for any questions, comments, reflections, or discussions from the group. Please feel free to share any thoughts or what we have heard and how these ideas may connect with your own work. Go ahead, Natalie. Thank you.
Hi, everyone, and thank you so much to all the presenters for this great session. It was a lot of, I think, really valuable detail and kind of building out some of the terminology around this, which I would say on the NGO side, which I represent with the G4 Alliance. I'm the advocacy manager for the G4 Alliance. We're a 70-member coalition that includes a lot of NGOs, professional associations, hospitals, universities, and some corporate members as well. But sometimes it's the language that is the barrier, sort of understanding the terminology, understanding the concepts. So it's been really helpful this session. I'm going to be sure to circulate this because we have a small group on today, but lots of people who are interested in this topic. So my question is, in these sort of like tiered financing structures where that there's that initial kind of like first loss, or now I'm forgetting the terminology already, but the first tranche of investment that helps to really de-risk, and that could include philanthropy. Could it also include NGOs that are receiving philanthropic money and could apply some of their programmatic resources towards in coordination within some kind of scheme? And I'm not sure if I'm explaining that fully correctly, so please let me know if you need any other details about my question. Thank you. And I guess this is mainly for Taylor, but for anyone who's presented today.
Great. Well, thank you so much. And, really happy to have everyone on. I think there is so much value in NGOs within the blended finance sector. I think that a lot of these structures actually can't be executed well at all without the NGOs and the programmatic resources that they provide, both in terms of financial resources, but also the great in-kind knowledge and networks that they have. So in some of the structures that we've had in the past, NGOs will actually be recipients of some of that that grant financing so that they're able to, do the on-the-ground mapping, help us understand where some of the gaps are, and help train, execute the work that needs to be done. So we see NGOs as immensely valuable, and as really without the NGOs on the ground, I think we would have a lot more problems seeing the impact that we do in these transactions. So I hope that answers your question.
It does. I guess maybe one follow-up question, because I totally agree with you. I think NGOs have such important implementation knowledge, and they can almost kind of validate some of the programs too because of their framing as being mission oriented. Um, is it possible, when you're kind of putting together these schemes and trying to recruit other sources of financing, to even take some of those existing programmatic resources that NGOs are currently applying towards a particular condition or within a certain program structure, to even like leverage some of those existing resources as part of the scheme? It's almost like these resources exist and you can build on top of something that's already happening. And it could even like recruit additional resources that way.
Yeah, absolutely. And we've done similar modeling to that. And Dr. Nardos, I know you were a part of that as well in looking at, we'll call that in kind. So we can bring in kind, and that will often count as that de-risking philanthropic layer because it's the resources that are already allocated that are already being implemented. So they can absolutely be brought into another structure as well.
Okay, great. Thank you so much. I really appreciate it.
Thank you also for attending Carolina Heilag's question on the chat. This Ruben, please go ahead.
I'm sorry. I think Dr. Carolina had a great question in the chat, and I see Elise replied. Thank you so much, Elise. Yeah, and we're hoping potentially we'll discuss very preliminarily because the group that organized this is going to reconvene pretty soon, maybe March next year again in La Sabana in Bogota. It does have it did require a significant lift in terms of resources, but we're going to hopefully look for opportunities to get additional funds to cover the cost. We want to make it bigger and more accessible, but it will require some additional funding. We'll go back to you, Carolina, because we know the WFSA is such a good, wonderful organization. You're leaders in the space, and as our panelists this morning have said, it is unreal that anesthesia and critical care are some of the least funded in the space. And I did have a question for Taylor. Taylor, it's good to see you. Going along the tone that Natalie was setting, at some point NGOs start to feel like, okay, oh my gosh, look at when they've mobilized these billions of dollars, and the amounts can be massive over time and quite impactful. But what is the entry point? If you're an NGO and you might not have 100 million to put in to do your first loss investment, what is a good like? What should an NGO who wants to get into the space be aiming for as an initial investment that might attract potential resources?
Great. Well, great to see you, Ruben, as well. I think there's two ways to go about it. One, as I mentioned, is the quantification of any resources that are already being provided by your NGO. I mean, I know Operation Smile does amazing work. So looking at in specific either countries that we're doing one of these larger transactions and saying, okay, we are already providing, X amount over so many years. And that can be quantified into a deal structure. I think the second thing is a lot of the time when we're looking at slides and you look at, okay, there needs to be hundreds of millions and billions, but a lot of blended finance, some of these really large deal structures come from an initial investment of a few 100,000 or $1 million. I mean, I think the best example of this in the healthcare sector is African Invest Transform Health Fund, where they initially received $1 million from USAID, which unlocked 110. The fund ended up closing at $111 million from that initial smaller tranche. And it doesn't always have to be a fund that's over $100 million. There's smaller, more regional or country level or city level transactions that can be done that may require a lower first loss tranche. And there's also a great opportunity for NGOs to work with foundations in terms of pooling resources. And that's where I think the matching commitments that I had previously mentioned can really mobilize.
Thank you,
Thanks as always, Taylor.
Got to have your hand raised. Go ahead.
Hi, Maria Jose and everyone. Thank you so much, Elise and the others for the presentation. I think it's always very good to hear from you. I'm always learning. And I was surprised about the data you mentioned about I don't know if it's the correct words, but like the growing and returning impact that Latin America has. And I think this is great that we're in the Latin American Working Group, Maria Jose, thank you, because we together work on the field itself. And, knowing these numbers and knowing the potential that we had as a community together, it really motivates us more to move forward in this. Do you have any specific examples, or do you can explain a little bit more about that data that you find and how maybe we could take advantage of that situation within the region and the work we do together?
Yeah, and is that the question on the $1 mobilizing 4.7
Yeah.
Latin America?
Yes.
Yeah, and I'm happy to also share some of that data with the group following this call. So this was a mapping done by Convergence Blended Finance. So they are kind of the global database for different blended finance transactions. In terms of how it can be leveraged, I think what the PGSSC team has done in terms of mapping the investments in surgical care and the existing financing that's moving within the space is a great entry point for us to think about how we can leverage that. I think it'll also require specifics around, what aspects of surgical care do we want to prioritize? How can we integrate some other aspects of health system strengthening, of maybe infrastructure that could bring in some additional development banks who are interested in that? So I think looking at the different mapping that there is, I know we had in Bogota the announcement of the CAF fund, which I think it will be really key for the region, as well as some of the climate financing in the region is really moving well. So if there's opportunity to find intersections between surgical care and climate, which, as we all know, there is, I think that that's a really great opportunity as well.
Thank you, Taylor.
Great to see you.
Thank you, Taylor, and everyone. If there's no other question, I want to really thank you so much to our speakers for sharing your time, expertise, and reflections with us today. I think this conversation has been extremely valuable because it reminds us that financing is not only a technical issue, but a critical condition for implementation. For Latin America, the challenge is now to move from that evidence and these different policy commitments toward these concrete, feasible, and sustainable financing pathways. So we're very grateful with the PGSSC and WEN for helping us thinking through both the evidence and the practical opportunities ahead. And we hope this is only the beginning of a broader regional conversation and hopefully of future collaboration around surgical system strengthening in Latin America. Thank you all for joining us today.